and the Customer Services Manager for Complex Care.
Our programme is the Pembrokeshire Care Closer to Home programme. It's about supporting people in Pembrokeshire to be able to live as independently as possible within the community. Our aim is to identify and manage people in the community who are most vulnerable. There are more older people in the county now than there are younger people. Like everybody else in the country, we need to stop unplanned admissions to hospital, unscheduled episodes of care. One of the big drivers were our customers who were fed up of repeating their stories to different professionals. They were also saying you could do this a lot more slickly and a lot more easily.
One of the difficulties for primary care was that in order to get support for patients in the community, there were several agencies that they had to deal with. There were social services, there was the third sector, physiotherapy, pharmacy.
We developed the 4 community resource teams across Pembrokeshire. We cut across all the organisational boundaries, health, social care and the voluntary sector and the GPs. We said it doesn't really matter who employs you. We want to bring you all together.
Community resource team has social workers, assessors, welfare assistants. It also looks at district nurses, occupational therapists, physiotherapists, dietitians, speech and language therapists and voluntary services brokers. And we come together once a week to discuss people who have high needs within the community, both health and social.
The team approach that we use in Pembrokeshire is something that we're actually very proud of because we've managed to sustain it over 2 or 3 years now, and it's embedded very much into the way that Pembrokeshire staff work. Our aspiration was to move into much more proactive practice, to have much more multidisciplinary response, looking at early intervention.
Before the community resource teams were implemented, what happened was that you would have a referral to the social services. You would have a referral perhaps to a district nurse, to an occupational therapist, to a physiotherapist, and each person would do their own assessment. And they would kind of work in isolation of each other. What this is aiming to do, and what we're proving to be successful with, is that we're doing one assessment with the added specialisms put onto that assessment. So we get a more holistic an approach to our work.
The headline indicators really that we've come up with is around reduction in emergency medical admissions, reductions in emergency packages of care, reductions in emergency admissions via A&E. We're also looking to reduce the average length of stay. So basically, as our services develop in the community and we know our patients and our customers, we need to be getting to the stage where those community services are then pulling those people back out again. And I think that's an aspiration and a further development that we need to look at. We also need to reduce readmission rates for those clients. And there are then some specific targets around percentage of customers or patients who are reporting that their quality of life and the level of confidence independence has been restored and improved following the involvement of CRT. A measure also to effectively demonstrate caseload management. Number 8 then is number of people who require a reduced health or social care package after a CRT intervention. And also quite importantly, and we had quite a lot of discussion about this on the away day, was around the staff themselves. You know, are they feeling actually happier that what they're doing is making a difference and therefore making them happy?
It has reduced lengths of stay in hospital and it has reduced unplanned admissions.
For everybody who has a service from the community resource teams, we provide a questionnaire for them, and they complete those, they send them in. It seems to be a positive experience. Obviously, people are seeing the difference and appreciate that they now have one key worker as opposed to everybody they need to contact. There are more people now receiving packages at home, and there is, I suppose, a decline in people wanting to go into residential or nursing placements.
I think there's been a need to recognise this isn't something that's going to transform care overnight. It's been quite a long slog for some people. And I think the skills in project management have been so very, very important in developing these changes.
I think it's successful because of communication. I think that's the key there, really. Health and social care colleagues work more closely together. We have better relationships with each other, and I think that that's really what's pulled it together. We're not working in isolation.
We didn't know when we started off what we didn't know, and as we've moved forwards, we've adjusted and developed.
The future, I think, will continue down this way. I think it has to. There has to be this integration between health and social care. There is only one lot of money in the pot, whichever way we look at it, and resources are getting less. Elderly population is increasing, chronic conditions are increasing, and if we continue down this road, hopefully we'll be able to provide a service that will meet everybody's needs.